Um, all right, so my name is Beth Patterson, and I work in Boston at Beth Israel Deaconess Medical Center. And I'm very excited to talk to you guys about nutrition interventions for liver disease. All right, so first let's start by talking about normal liver function. Interestingly enough, our liver does a lot, especially related to nutrition. It's involved in all macronutrient metabolism. In glucose metabolism, it produces and stores hepatic glycogen. It's involved in lipid metabolism because it produces bile, which helps for lipid absorption, and it also forms triglycerides and synthesizes cholesterol. And it's also involved in protein metabolism. It produces 85 to 90% of all plasma proteins, things like albumin and clotting factors. And it also breaks down proteins into amino acids for gluconeogenesis. Your liver is also involved in micronutrient metabolism. So it stores, it metabolizes, and it digests a lot of our micronutrients. As I talked about, it produces bile, which is required for fat-soluble vitamin absorption. It stores fat-soluble vitamins. It also stores iron and copper. And it's involved in vitamin A, D, and E metabolism. And it's also involved in drug metabolism because our liver transforms and detoxifies drugs. So what happens when your liver doesn't work or it's diseased? As you can imagine, there's a lot of fallout from that. So different types of liver disease, and there are many. You can really categorize them into two basic categories, which are acute liver disease or acute liver failure, which oftentimes can progress into chronic liver disease. So acute liver disease, hepatitis like Hep C virus, Hep B virus, alcoholic hepatitis, again, which can develop over time into chronic liver disease. Acute liver failure, drug-induced liver injury, like for example, an acetaminophen overdose, hematochromatosis, which is a genetic disorder that causes iron overload, all of which these things can develop into chronic liver disease. Chronic liver disease is characterized by cirrhosis, and cirrhosis is just severe fibrosis of your liver. Cirrhosis can be compensated, which means your body is doing a pretty good job of keeping things together and still functioning properly, but oftentimes develops into decompensated cirrhosis. And that's when we see all the sequelae of liver disease. So we start to see things like ascites, esophageal varices, hepatic encephalopathy, hepatorenal syndrome, spontaneous bacterial peritonitis can occur. And when we start to see these decompensated cirrhosis symptoms and signs, that's often when patients are moving towards transplant. So compensated cirrhosis moves into decompensated cirrhosis. That can oftentimes develop into hepatocellular carcinoma, so a cancer of the liver. And another one that you hear often of is a non-alcoholic fatty liver disease or non-alcoholic steatohepatitis, again, which are more chronic diseases that can progress into decompensated liver disease and then potentially hepatocellular carcinoma and need for transplant. Okay, so we already talked a little bit about the complications of liver disease. As you can imagine, if your liver doesn't work, there's impaired energy and macronutrient metabolism and storage. It's involved in all three macronutrients. And then there's also impaired micronutrient storage and activation metabolism. So nutrition can go haywire pretty quick. Portal hypertension is certainly an issue that can also lend towards impaired nutrient absorption because there's inadequate hepatic blood flow. Portal hypertension also causes things or can cause things like esophageal varices, ascites, which can become a major barrier to a proper PO intake, and then also hepatic encephalopathy, which we'll talk about more. So these patients, as you can imagine from what we've already talked about, are at extremely high malnutrition risk. And it's estimated that up to 75% of patients with liver disease have malnutrition. In addition, they have water and or fat soluble vitamin deficiencies. And why is that? Well, we already talked about the impaired nutrient absorption, so that's an issue. In addition to that, they have increased needs because they have altered fuel metabolism, and they can become extremely hypercatabolic. And on top of all that, they generally have decreased energy intake and inadequate PO intake. So they need more energy, they need more calories and protein. They generally don't absorb as well what they do take in. And on top of that, many of these patients don't take enough in. So it's kind of triple fold all the issues. What are the potential barriers to PO? One of the biggest is early satiety. So liver patients oftentimes become very bloated, have abdominal distension from ascites. So they have a lot of fluid on board, and that keeps them from being able to feel like they can get any food down. A lot of nausea and vomiting, delayed gastric emptying. On top of that, many of them are prescribed restricted diets. So they do need a fluid restriction. They need potentially a low sodium restriction because they do have so much volume overload. So now they're restricted in what they can take in. If a hepatorenal syndrome is a piece of the puzzle, they may also have renal restrictions on top of that. Again, low appetite. Encephalopathy can be a huge issue. So their mental status just isn't there. That's not what they're thinking about, is eating. And then, as you can imagine, many of these patients, if the etiology of their liver disease is alcoholism, the so-called liquid diet, where they're just drinking, they're not eating, can also obviously lead to, significant barrier to PO and significant malnutrition. So how do we assess these patients? What are we going to do with them when they show up? The info that we want to gather as best we can, let's get a history of what they have been taking in. Do a diet recall if they're mentally with it and able to tell you. An NFPE can be very, very helpful in these patients, sometimes very challenged by a lot of fluid on board, and it's very difficult to assess when a patient has extreme lower extremity edema, for example, but do the best you can with a nutrition-focused physical exam. Ask them, what are their barriers to intake? Is it diet restriction? Is it because they have early satiety? Are they nauseated? And seeing if there's anything you can do about those barriers. And then one of the biggest and probably most important pieces of the nutrition assessment is trying to get an accurate weight history and a dry weight or an estimated dry weight as able. And what I find is that many of these patients can tell you, they are very well aware of, without the fluid on board, this is what I am supposed to weigh. And they're able to, they weigh themselves often, and they know when they have a lot of ascites or fluid volume overload. Some aren't going to be able to tell you much. So the challenge is to gathering this information. Encephalopathy, poor historians, patients that just can't tell you what they eat. They have no idea what their weight is, what a true weight is. And then, of course, in terms of knowing a true weight, there's definitely a challenge of the fluid being on board. So edema, ascites, that type of thing. What if you have a patient that has no idea what their true, so-called estimated dry weight is? What do you do? We have some ways of guesstimating a dry weight by adjusting for ascites and edema. And this is pretty well documented in the literature. So if you have a patient with small volume ascites, you can subtract 3 to 5 kilograms from the weight that they come in with. 7 to 9 kilograms for moderate volume ascites, and up to 14 to 15 kilograms for large volume ascites. So that can tell you how much fluid these patients can have on board. What if you don't really know how to figure out, well, I don't know if it's small or moderate or large volume ascites? A lot of times doctors, the hepatologists will be documenting, sort of that, give you an idea of the size of the volume of ascites. If it's edema, that's the issue. You can subtract 1 kilogram for mild, 5 kilograms for moderate, and up to 10 kilograms for severe edema. So this is just a way, again, of trying to get a usable weight to estimate needs without all the volume on board. Okay, so now what are their nutrition needs? As we know, they're elevated. These patients are hypermetabolic and hypercatabolic. If the patient is not critically ill, so they're not in the ICU, again, we're trying to figure out the best estimated dry weight, and that's the weight we're using for the nutrition needs. For cirrhosis, we use 30 to 35 calories per kilogram, and that's compensated cirrhosis. For decompensated cirrhosis, so when they really start to have all the sequelae, we use 35 to 40 calories per kilogram. Alcohol hepatitis, 35 to 40 calories per kilogram. And the non-alcoholic steatohepatosis or non-alcoholic fatty liver disease is the only place where the calorie needs are reduced. At which point we would use 25 to 30 calories per kilogram, or we would just reduce their needs by about 500 to 800 calories. If the patient is critically ill, we just follow critical care guidelines. Again, ideally using estimated dry weight that you would generally use in the ICU, not specific to liver disease. In terms of protein, we use 1.2 to 1.5 grams per kilogram. A protein restriction is not indicated, although, historically back in the day when I was first a dietitian, over 20 years ago, if a patient had high ammonia levels, we were, restricting their protein a bit, sometimes all the way down to 0.7 grams per kilogram or 0.8 grams per kilogram of body weight. So it was historically thought to benefit encephalopathy, but at this point we know that protein restriction is not indicated. High protein diets actually improve outcomes, and it can help maintain lean body mass and promote gluconeogenesis. So we know these patients are at very high risk for loss of lean body mass, so protein can help here. And we also know that high protein diets do not exacerbate encephalopathy. What about branched chain amino acids? That's prominent in the literature. So there is promising literature, but there's no real consensus or supplementation recs. What I will say is it seems to be most promising for patients with refractory encephalopathy. And then these patients often need a fluid restriction. So you're looking for, whether it be in diet or tube feeding, however you're intervening nutritionally, you're looking for concentrated formulas, that type of thing, with or without a sodium restriction. Again, all just depends on their volume status. The goals of nutrition therapy, we want to maintain or improve overall status, nutrition status, minimize malnutrition risks. That's always the goal, right? Maintain or increase lean body stores, maintain micronutrient stores and replete as needed, because again, they're a high risk for micronutrient deficiencies. Encourage high calorie, high protein diet, small frequent meals, avoid skipping meals, which we'll talk a little bit about more. Utilizing liquid calories as needed. So oral nutrition supplements are a great way to get a concentrated high calorie, high protein formula in, smoothies, that type of thing, and follow low sodium and fluid restrictions as needed. A lot of times liberalizing the diet as much as possible, especially if that's one of the significant barriers to improved PO intake, is a good goal or a good way to look after it. And then avoiding prolonged fasting. So remember, these patients don't have normal functioning livers that can store glycogen well. So we definitely want to avoid fasting as much as possible. That's why the small frequent meals are important. And also really encourage a bedtime snack. So if a patient goes for a prolonged time, they don't have the glycogen stores to call upon, so muscle catabolism happens. And again, this is why they can become easily malnourished. An overnight fast in a cirrhotic patient is very can be equivalent to a 3-day fast for a healthy individual. So as you can imagine, that bedtime snack can actually play a huge role in them being able to maintain muscle mass. And then finally, let's talk a little bit about micronutrient considerations. Fat soluble vitamins deficiency is common because they don't the intake isn't there. They don't absorb the fat soluble vitamins without without bile, impaired synthesis and activation and storage. Vitamin D, most liver disease patients have some degree of vitamin D deficiency and need repletion or supplementation. Water soluble vitamins also can be an issue. Impaired absorption, alcohol can play a big role here. Just poor intake of water soluble vitamins. Thiamine and folic acid in particular generally need to be supplemented, especially if there's a history of alcohol use. And or for thiamine, a lot of these patients are prescribed diuretics because of their volume status. So that can also play into thiamine deficiency and a need for supplement. In terms of minerals, zinc is often malabsorbed, plus they're not eating it as much with decreased POs. And then finally, a lot of these patients are on lactulose, so they have many bowel movements a day, and that increases the risk of zinc deficiency because of increased loss. One interesting thing is that patients with liver disease that have elevated total bilirubin, oftentimes if their T-bili is greater than 5 milligrams per deciliter, we hold the minerals because of the risk of copper and manganese toxicity. So we would just supplement with a multivitamin without minerals. Thank you very much for listening to our video. And there is a part 2 coming up, so please stay tuned. And if you have any questions, just put it in the comment box below. Thanks, guys.